Welcome to AETCM, the Emergency Medicine channel. Ma'am, today we are going to discuss a orthopedic case.
Okay.
Shall we start?
Yeah.
A 11-year-old female, no previous comorbidities, present to the ER with alleged history of slip and fall, hit her left clavicular area on the bed end, sustaining closed injury yesterday night. On our initial 10-second assessment, patient was conscious, oriented, and obeying commands. The left arm was adducted and was supported by the other arm.
Oh.
Coming to the primary survey, the airway was patent, urinary bilaterally equal, no pooling of saliva, no increase in secretions. Breathing respiratory rate of 20 per minute, saturation of 97% in room air. All peripheral pulses felt equally on both sides. Coming to circulation, heart rate was 95 beats per minute, BP of 100/60 millimeters of mercury. At this point, we inserted one IV cannula. Disability GCS 15/15, bilateral pupil equally reacting to light. The restriction of movement of left upper limb was noted. The upper limb was supported by the other arm. There was a pain score of 6/10. At this point, we have given injection paracetamol 10 mg per kg IV stat.
The analgesic dose of paracetamol is 15 mg per kg. Okay.
Then coming to the exposure, temperature was 97.8 degree Fahrenheit, blood sugar of 160 milligram per deciliter.
Okay. So this patient is having, this patient came with a slip and fall, and only thing we could find in the primary survey is she is having a shoulder injury, left shoulder injury, as her shoulder hit against the edge of the bed. Okay. And her pain score is elevated, so you gave paracetamol. So you anyway told the dose, that is 15 mg per kg is the paracetamol dose. So this is a 11-year-old female, right? So what cannula will you place for her?
We can place a 20-22 gauge.
Yeah, 20-22 gauge cannula. So can you tell the different cannulas? What all colors are there in cannula?
18 gauge cannula.
Okay, 18 gauge is there. 18 gauge, what is the color?
Green.
Green is the color. Okay, next.
20 gauge cannula. Usually pink in
Okay.
color.
Then
22 gauge cannula.
22.
Gray.
No, gray is actually 16.
16
is gray. Okay. Then one 14 is there. That is orange in color. Orange color. Okay. 22 is which we usually see near, other than green and pink. Blue. Okay. 20. 24. 24 yellow. Usually we see in pediatric ER yellow. Okay. 26 is violet. So these are the colors. So in this female we can either place 22 or 20. Okay.
And coming to the ambul history, no allergic history, not on any medications, no similar episodes in the past. The last meal was taken 4 hours back. Coming to events, the 13-year-old female, no previous comorbidities, presented to the ER with alleged history of slip and fall, hit her left clavicular area on the bed end, sustaining closed injury yesterday night. No history of any LOC, vomiting, blurring of vision, and headache.
Okay, so only the injury which we feel is that clavicular head injury, as a history of the shoulder region. Okay, so what other history we should ask for in her other than the LOC, vomiting, seizure, that we are asking why? To rule out any intracranial lesion, head trauma. Okay, other than the clavicular region per se, what else should we ask?
Sensations.
Okay, sensation. So brachial plexus may be injured. So sensation of the upper limb should be asked. Then power. Any weakness or anything is there. Then other things. Shoulder region.
We can ask for neck pain.
neck pain can be there. Any problem in breathing, if she is having some breathing problem, what we should...
Fractures and things, the pneumo we can
So if the patient is having a fracture to the first 3 ribs, that means it is a severe mechanism of injury. So that itself can cause many problems. Along with that, if there is any injury to the neck, there can be phrenic nerve involvement causing a diaphragmatic palsy. Okay, and if the mechanism is very severe, that can affect the internal vessels also. Then what else should we ask? Then if it is involving the neck region, there can be associated
tracheobronchial injuries.
Tracheal bronchial injuries can be there, dysphagia can be there, breathing difficulties can be there. So we should also ask for any such things are there, any hoarseness of voice or anything. And along with that, during inspection, we will have to take care of the larynx, these part, and we should properly examine for any laryngeal fractures, any subcutaneous emphysema or anything. Okay.
Coming to musculoskeletal examination, the gait was normal. Head to toe examination, head, no facial injuries, no facial asymmetry. Coming to neck, no C-spine tenderness. Coming to inspection of the left upper limb, after obtaining consent, we have went for inspection. The area was adequately exposed and inspected from anteriorly, posteriorly and laterally. Coming to the attitude of the patient was supporting the left upper limb with the right arm. There was a deformity noted over the shaft of the clavicle. There was no wasting, scars, sinuses, dilated veins or visible pulsations. Coming to palpation, we palpated from the sternoclavicular joint to the acromion. There was no local rise of temperature. There was tenderness over the shaft of the clavicle. Over the shaft of the clavicle, we were able to make out a crepitus. There were abnormal movements also present. Bony discontinuity was present as we palpate from the sternoclavicular joint to the acromion. The range of movements were not able to assess properly as the patient was having pain. We have examined for the distal neurovascular examination, which was found to be normal. No neurological deficit at present.
So this is a female patient, right? So when you're planning to examine the patient from inspection, what we should do?
Obtain a proper consent.
Proper consent should be there, and since it is a female,
we have to arrange a female bystander.
Female bystander also should be there, and patient should be undressed. And first, when we are examining, we should, as you rightly told, from anterior side and posterior we will have to examine, and we will have to look for the attitude, any scars, any other injuries, any bleeding or hematoma, anything is there, and attitude and position, any muscle wasting, these things should be properly examined. And before doing palpation, we will have to explain the patient and we will have to offer analgesics again. The patient is still in pain, then we will have to give analgesic and then only start palpating. Okay. Okay. So you told that there is tenderness over the shaft of the clavicle. Which part?
The middle 1/3 of the part.
Middle 1/3. So this much findings you got. Where are you expecting the fracture in this patient?
The fracture is expected most commonly around the medial 2/3 and the lateral 1/3 area.
Okay. Okay. So middle 2/3, that is the most common site of the clavicle fracture. So if it what was done then? Okay.
Then we went for a chest X-ray, which showed a fracture of the left clavicle at the middle 1/3.
Okay. 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 So the middle 1/3 fracture is seen right here. So where is the most common site of fracture? As you told. Otherwise, when you divide the clavicle into three parts, there is medial 1/3, middle 1/3 and lateral 1/3. So the fracture here is, the possibility of fracture is only 5% here. And in the lateral 1/3, the possibility of fracture is 15%. Why it is less? Because it is fixed to another bony structures and muscles. And here the probability is 80% for a fracture. Suppose this patient is coming with fracture over the medial 1/3 or the fracture of the sternoclavicular joint. then that is either it can be because of severe mechanism of injury, or patient might be having any connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, or any ligament laxity syndromes and all. If this patient is coming, so this patient anyway it is like 80, in the most common side, the middle 1/3. So why this clavicle is looking displaced like this?
Because the attachments of the clavicle.
Okay.
Here the clavicle, the medial end of the clavicle is attached to the sternocleidomastoid, which pulls the medial end of the clavicle upwards. Whereas the weight of the humerus and also the pectoralis muscle will pull the clavicle downward. That will pull the lateral part of the clavicle downward. That is why the clavicle is.
That is why the medial end is going superiorly and the lateral end is going inferiorly. Okay. Okay.
So coming to our diagnosis, it is an isolated shoulder injury involving the left clavicular fracture, medial 2/3 and lateral 1/3 of the clavicle, Allman classification 1 with no neurovascular deficits.
Okay.
Coming to the management, there are both operative and non-operative methods.
Management in the ED, what will you do?
We will give figure of 8 bandage and
first in the ED we will have to immobilize the patient. We can, if the patient is having severe pain, we can apply cold pack or ice pack or something there. Then we can give a immobilization can be done, or we should give analgesics or immobilization. Both should be done ideally. So both can be done. So how first, if you have already given paracetamol, can give ice packs also. Then we will have to plan on immobilizing. Okay. What was done?
We went for the non-operative approach, as conservative management is the treatment of choice in clavicular fracture. Two approaches were there. Figure of 8 approach which will make the medial end of the clavicle to its normal position, and the shoulder brace which will position the lateral end of the clavicle to its original position. Both shoulder brace and the medial figure of 8 bandage was applied so that the approximate the fracture site. And then we will review after a few weeks. If there is proper joining, then we will go with the conservative management. If not, it will take the patient into surgical management.
Okay. When all will you inform the orthopedician on call if the patient is coming like this directly to the ER with shoulder fracture, like clavicular bone fracture?
If there is any open fracture, massively displaced fracture, if there is any neurovascular deficits like brachial plexus injuries there,
there is severe pain, such cases we will have to inform orthopedician. Okay. So this is a 11-year-old female. Suppose she is having an injury to the elbow. 11-year-old female with injury to the elbow. So what all do you know what are the ossification centers in the elbow? When all it will ossify? So there is something called as crypto. So since she is 11 years, I just told. Elbow, there is 1, 2, 5, 7, 9, 11. And we will write crypto on the side. Okay. So at 1 year of age, the capitulum will get ossified. And 3 years of age, the radial head will get ossified. 5 years of age, the internal or the medial epicondyle will get ossified. At 7 years, the trochlea will get ossified, and at 9 years, the olecranon will get ossified, and 11 years, the external or the lateral epicondyle will get ossified. So, if this female is coming with an elbow injury, and if we are taking an X-ray, all the ossification centers might have ossified in her. Okay. Okay. Then what was done? So we gave her analgesics. We placed what this thing was done.
Figure
Of bandage was done, and we
Shoulder
asked
brace was also given.
and we asked her to review in the orthopedics
OPD.
OPD. Okay, thank you.
Thank you.